just plunking it in there. So I gave this paper at International Health Economics Association meetings, kind of aggressively asking the question, is propensity score just an inferior version of instrumental variables? And it just got me thinking about instrumental variables in a much more critical way. So I've actually come around to the fact that I think propensity score is a better way to go, but we'll get to that in a minute. So there's lots of examples of now of the use of instrumental variables in the health economics literature. And the most famous citation is McClellan, McNeil, and Newhouse, who used distance from cardiovascular centers as an instrument for sort of access to care and severity, because people that are really severely ill and are having an AMI are likely to go to the local hospital, but that's not a very good measure of whether or not the intervention is a more intensive intervention is successful or not, because it's confounded by the fact that they're just being taken to the nearest place. So the idea was to try to control for that and tease it out so that you could measure the whether going to a cabbage facility, for example, actually resulted in better outcomes. So not surprisingly, distance is very often used as an instrument in outcomes research. I mentioned that this instrumental variables came out of this kind of labor agricultural economics literature originally, but those data were very simple. They were interval data, regular regression models, and so forth. And so what's happened as claims data began to become available in the late 70s, early 80s, we're kind of wrestling with these discrete choice problems of where you've got 0 1s for a dependent variable, somebody gets a drug or not. You've got lots and lots of data, a lot of variables. And those are not kind of the simple ordinary least squares problems. But they were very similar. These outcomes research questions were very similar to the problems that economists were wrestling with in the labor economics literature in the mid-70s. So, there the challenge was the economists were kind of naturally interested in whether or not, or what the relationship was between the number of hours that people were willing to work and the wages that were being paid. But it was like that censored sample example I gave you. You were only observing that for the people that were in the labor force. You're only observing the wage hours relationship for the people in the labor force. And so economists said, well, what if it's the fact that some people aren't working because the wages aren't being offered, that aren't even high enough to entice them to be in the labor force? And this became known as the reservation wage. What is the wage that would be needed in order to entice people to go into the labor force? But in these big national probabilistic surveys from Bureau of Labor Statistics, what you had samples, and you could observe whether somebody was in the labor force or not, and you had data on the whole population, random samples of the whole population, so you could model whether somebody was in the labor force or not, just like that drug selection equation. And you had things like, marital status and income and numbers of kids at home under the age of 6 and things like that, and you could model that, and then you could subset down on the patients that were in the, employees that were in the labor force, and for those employees that are in the labor force, you could get those error terms from that selection equation and plunk those in. So that was the idea, and this so it started to become applied to labor economics. So when I left Brandeis and I started working at MedStat, I was doing policy work on Medicaid expansions for the aged and disabled. And I got a call out of the blue one day from somebody in the MedStat pharmaceutical consulting business. They said, do economists have any methods for dealing with sample selection bias? And you could sort of see this same statistical problem for the outcomes research as it was for the labor economics. So I spent the next 15 years doing application of econometric methods to outcomes research. But there was a lot of times when I got questions around from reviewers around endogeneity. So the reviewers would come back, and I'd have run a regular regression model, and the reviewer would come back and say, well, there's these potential sources of endogeneity. Did you test for it? Did you correct for it? And you go off and you do instrumental variables, and you get almost the same answer, but the standard errors were bigger. And what always got published was the more sophisticated method, the instrumental variables method. So the question was that really the right answer? And particularly because there's been a lot of evidence from labor economics that these instrumental variables methods have a really, really big standard error. And there's some other issues associated with them. So how well do they really perform in actual practice? So my very first example in the antidepressant work was comparing SSRIs against tricyclic antidepressants. And Group Health Puget Sound was doing a clinical trial on this question, and we were doing some work for Eli Lilly at the time. And they said, well, do you think the FDA would ever take this as, if we did one database study and we did this clinical trial in Group Health Puget Sound, we got similar results, do you think the FDA would sort of take that as two well-controlled studies? I said, I don't know. I didn't know anything about this business. But I said, I think it's appropriate to sort of do these kinds of methods. And so we did, and we modeled that. First equation is modeling the drug choice. So whether or not somebody got an antidepressant, tricyclic versus an SSRI. The second one was the drug use pattern. So how many days did they stay on the drug with drug as an explanatory variable now? And then I ran separate models for the SSRI group and the tricyclic group, which would allow drug basically to interact with every single variable. And what we found when we looked at the data was that this was kind of the classic case where at the time people were talking about the evidence from the clinical trials. And the evidence from the clinical trials was that the treatment effect for SSRIs was essentially exactly the same as the tricyclics. It was about a 50% response rate in the clinical trials. And so the big prescription benefit manager companies were saying, well, why would we ever reimburse for an SSRI that costs 10 times tricyclic when they've got the same clinical efficacy? But when you looked in the data, the patients that initiated on the SSRIs were much less expensive in terms of total healthcare costs than the patients that initiated on the tricyclics. Interestingly, they were almost exactly the same in terms of any claims that had a mental health diagnosis on them. So, virtually a dead heat. But where you saw the difference was in the non-mental health. And so actually these graphs were very helpful to us because as we thought about this, how does somebody get into treatment for depression? Well, they go into the doctor and they're complaining about headache, complaining about the fact they're not sleeping well, they've lost their appetite, they've got back pain. Finally, the doctor says, I bet they've got depression. And they put them on an antidepressant. So to the extent that somebody stays on the antidepressant longer to resolve the underlying depressive symptoms, where you see it is actually in the non-mental health claims, because all that stuff is showing up in the database as medical expense, but not mental health expense. So I learned two things there. One's the difference between, a number of things. Difference between effectiveness and efficacy. The fact that you can't look just at the disease-specific costs. You've got to look at the broader costs. And think about it now in terms of trying to analyze healthcare outcomes for medically complex populations, which is a big research area, or trying to understand healthcare utilization and outcomes for the elderly, which have all these comorbidities. you've got to have this broader view of the patients. So the upshot was that we did find selection, but we found it with the tricyclic group and not with the SSRI group. And I think the reason was that there's an issue with respect to tricyclics in terms of suicidality potential. So people could take them to commit suicide. They're dosing specific. So the psychiatrist would be familiar with the dosing for tricyclic patients, whereas primary care docs would be much more comfortable prescribing the SSRIs. And so I think as a result, the sicker patients tended to be getting the tricyclic antidepressants because they were seeing psychiatrists. So that was the hypothesis. And that's why we set it up where with the drug choice, one of the explanatory variables was the provider type, whether it was a psychiatrist or a primary care doc, and then the drug use pattern, because we felt like the drug use pattern was really going to drive healthcare outcomes, and then separate equations for the two groups. Yep. I think I'm being timed out.
Let's restart. Seems fine. Okay.
So this last little bit is just going to give you some simulation results where I basically kind of invalidated 15 years of my own work. But Brandeis's motto was truth unto its innermost parts. So I tried to do that. So let's see if I can skip through these. I should stop and give you a quiz. Okay, so one of the, so there was a literature that showed that weak instruments can not only lead to bias, but also not only large standard errors, but also bias. There's quite a large literature in this area, mainly in labor economics. But there was a theoretical paper that was written by Bound, Yeager, and Baker in 1995, where they basically proposed a relationship between the strength of the endogeneity problem, the strength of the instruments, and whether or not there was still residual correlation of the instruments with the error term. And they provided this kind of graphical analysis of this. And so basically what we did was we just replicated the Bound, Yeager, Steger, Yeager, Bound, Yeager, and Baker results with an empirical simulation where we knew what the treatment effect was, and we just went right through their paper. We also looked at sample size, which is important in the big data environment. As it's not, I would just say that it's not generally understood in the big data world that more data doesn't solve the bias problem. So having more and more and more and more claims data is not going to solve the bias problem unless it helps you to link to data that are missing. Because otherwise, actually, you just end up getting really precise measures of bias in that case. So we wanted to estimate the treatment effect, and we've got some conversion issues here. But the this first equation on the upper left-hand side is the correlation between the treatment variable and the instrument. So we're saying we're going to start with an example where we've got a 40% correlation between the instrument and the treatment session. Really, really strong instrument. So this is a kind of a best case scenario in terms of instrument strength. And then we're also going to take an example where we've got a really, really bad endogeneity problem. So we've got a correlation of 40% between the treatment variable and the residuals in the outcome equation. So Really strong instrument, really bad endogeneity problem. Exactly the kind of case when you should be using an instrument. But we're going to start out with a smaller sample. So in this first example, we're assuming there's no correlation between the instrument and the error term. So we've basically got a perfectly clean instrument. So in the case of a perfectly clean instrument, if there's no bias, the difference between the true value and the estimated value is going to be 0. So for any particular sample, we could be here, we could be here, we could be here, we could be here. But the sampling distribution, we want it to be centered over 0 in order for our estimator or our statistical approach to be unbiased. And sure enough, instrumental variables, which is the blue line, is centered right over 0. So in the case where we have a perfectly clean instrument, we have no bias and it's centered right over 0. No bias and it's normally distributed. In the case of ordinary least squares, where we have completely ignored the endogeneity problem and just run the treatment effect estimate, which in a sense is what we're doing when we use claims data alone, and we're not trying to correct for missing variables. We have a biased estimate, but notice that it has a smaller standard error, but it's still biased. So in this case, we would probably, I think we'd pick everything else equal, not knowing which sample we had, where we were on these distributions. We'd want an estimator or approach that was going to give us an unbiased estimate on average. So instrumental variables looks pretty good for this case. Now, in this upper panel, if we have an 8% residual correlation between the instrument and the error term. So it's not a big correlation, but an 8% correlation between the instrument and the error term. They're both equally biased. So both ordinary least squares and instrumental variables are now biased. Instrumental variables has a bigger standard error associated with it than ordinary least squares was. But again, it's not really obvious which is the better method, because all these estimates in the area under the curve here is probably bigger in instrumental variables than it is with ordinary squares. But it's kind of a coin flip. Now, if the correlation isn't 8%, but it's 16%, actually, instrumental variables is even more biased than ordinary least squares was. And this is completely ignoring this really strong endogeneity problem. So we've got a 40% endogeneity problem, completely ignoring it, and we're doing better with ordinary least squares than we are with instrumental variables because of this variability problem here. And so this is of concern because it's so hard to find these instruments that invariably economists are leaning over backwards to find these instruments, and they're almost always weak. And because they're weak, it raises the chances that you've got residual correlation because you're not really controlling for everything. So here's exactly the same situation, but we just upped the sample size from 200 to 2,000. And so we have unbiased instrumental variables, biased ordinary least squares, but really tight variance. They both have tight variances. And so this is the point about bigger samples don't do away with the bias. What it's done is it's actually completely separated the distributions. So in this case, what it means is that you just have a more precise measure of what the bias is, which that's not a bad thing, but it doesn't solve the bias problem. So here's the case where we just changed the, we cut the degree of the endogeneity in half, and we also cut the degree of the strength of the instrument in half. So we went from 0.4 to 0.2 in each case, and we go back to our 200 sample. But look what happens when the instrument isn't as strong anymore. When the instrument is only half the strength, it just flattens right out. So now, with any particular sample, your chances of being off in the tails with instrumental variables with a weak instrument are really high. And you could do a lot worse, with instrumental variables than with ordinary least squares. We see the same general patterns, but notice that we cut the endogeneity and strength of the instrument in half, and the thresholds that create these challenges here are also cut exactly in half. This is what Baumjager and this is exactly what they had proposed. This relation, the strength of the instrument, the strength of the endogeneity, and the strength of the residual correlation would have this relationship. But I would argue this is probably a more realistic case in terms of the instrument strength, because we generally don't have really strong instruments. And then here's what happens with 2,000 observations, and then with 10,000. You just it just gets more and more precise. So the bottom line is that I think we're sort of in a new world, in terms of our ability to do good observational studies and link data together to be able to tackle, these challenges. Any observational study is going to have these challenges that we've been talking about, but our ability to attack them is so much greater than it has been. And it's just, these data cooperatives are just springing up all over the place. I think even though I've definitely been negative with respect to IV, what I'm doing as a result of that simulation work, I'm really kind of focused on data because I'm not very sanguine about the ability for statistical methods by themselves to overcome, severe data limitations. I think we've got to focus on the data. But then the methods themselves are still valuable because they give you a test. If nothing else, they give you a test for whether you've got an endogeneity problem or not. And that's a really important thing to know because, if you have that, significant coefficient on that error term variable that you've got in your outcome equation, it tells you, I should be cautious about the strength of the evidence that I'm, getting from this study. I think one final area that is very interesting is what do you do when you can't link the data or you can't link all of the data? So I mentioned that in Optum Labs, we've got this 149 million lives of claims data, and then it's actually about 37 million lives of electronic health record data. And we know that they have an overlap of about 15% because we've looked. We're now linking that overlap, that band together. So we're going to have 5 or 6 million patients where we've got all the claims data plus all the clinical information that we have from the Humedica database. But you don't want to throw away 145 million lives of claims data and 32 million lives of electronic health record data. So what can you do? I mean, does it have to be the same people? Can you impute clinical distributions, for example, multiple times to the people in the claims data and then be able to have those distributions of clinical distributions as control variables? And if you do, what are the properties of the estimates that you get on the supersample versus the subsamples? And so what methods are the best methods and so forth. So one of the areas that we're very interested in is kind of the statistical infrastructure around data linkage. Because it's interesting, when you look in the literature, most of the literature is focusing on the errors that get introduced by imperfect linkage. But that's kind of a secondary question. the real question is the reason you're doing the linkage in the first place is to reduce the bias by just having the just a select set of the data alone. So we really want to look at what's the bias, if you have claims data alone, what's the bias when you have the clinical, and then how does that get affected by imperfect linkage and by these multiple imputation techniques and so forth. So with that, I think I'll stop and see if you guys have questions.
So do statins make people live longer?
I think certainly from the standpoint of the evidence was flawed in terms of the modeling that was done for that question. Because the models, just couldn't replicate the mortality or event rates, and they overstated the event rates by about twice, which interestingly was the amount by which they recommended the expansion of the statins into the population was about twofold. So I'm not sure that, I think there's a lot of evidence that statins certainly save lives for the population that should be on them from the Framingham Heart Study, which is, of course, an observational study. But I'm not so certain that there's a lot of convincing evidence that they should be dramatically expanded.
The actual data issues with observational data and statins, you're interested in applying these methods?
Yeah, cardiovascular is one of the areas where I think there's a lot of potential. So, we've had the Framingham Heart Study data, but these big observational databases have a lot of data that probably is not in the Framingham Heart Study around healthcare utilization and broad-based medical comorbidity, and I think one of the areas that's really challenging from the standpoint of medicine is what do we do with these patients that are medically complex? So we've got guidelines that tend to be, they're disease-specific guidelines, cardiovascular guidelines, diabetes guidelines, guidelines for treating asthma, and so forth. And so they're disease-specific guidelines kind of treating the patient in the silo. But if you take cardiovascular patients, for example, this is kind of the classic, group that's likely to have metabolic syndromes. They're likely to have cardiovascular issues, blood pressure problems, obesity, hypertension, and hyperlipidemia, all these things together. And then to boot, they may have depression, or they may have, breast cancer or whatever. So what do you do with a patient like that? We don't have any guidelines for that. So a physician treating a patient is going to treat them right now. They're going to treat them for whatever it is they're seeing them for. And if they're a primary care physician and they're aware of all these other things, they're going to have a hard time figuring out what to do. Because there may be, if there's 3 conditions and there's 5 top priority things that the physician should be doing for each of the 3, there's 15 things. Well, which 15 should they do, and how should they prioritize those? So one of the things that's really interesting, I think, is I didn't talk about machine learning methods, but one of the things that machine learning does really, really well is put people into groups. So you could find patients that are really similar to the patient that is in front of the physician and say, what were the treatment options that were, and do this in real time. Have technology that will do this in real time and present the physician with options and say, here are the things that have been done for patients just like this patient that's in front of you, and provide guidance. So maybe that means that we go completely away from clinical guidelines at all, because as soon as you start getting into this medical, complex area, you can't have guidelines for all these things. It doesn't really make a lot of sense. What you need is a patient, a way to treat a patient with these conditions rather than treating these conditions. But what I worry about with the machine learning is that the machine learning will put patients into groups. Um, and we've got, sophisticated methods for analyzing treatment effects for those groups. But the machine learning methods don't worry about what's not in the data. So the idea, the way an epidemiologist or a health economist would think about estimating a treatment effect is they would be very concerned. Do I have all the variables? And if I don't have all the variables, how can I, deal with that? And whereas machine learning methods are just kind of, put everything together, put people into buckets. They're going to do that really well. So I think actually it's where the power may be is machine learning as a first step. Machine learning as a way to define the groups, and then the analysis of treatment effects within those groups using more traditional methods. Yeah, right. No, that's definitely true. Yeah. 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 And I mean, that's one of the things that, the machine learning methods do, by construction in order to avoid the kind of the overfitting problems is they create these, these groups and then create sort of test samples, learning samples, and then test samples, which is something that should be done, much more systematically and much more commonly in epidemiology and health outcomes, but it's not done that much. Yes. Yeah. Yeah. The bootstrapping methods um, won't solve the bias problem, but in terms of the work that we're going to do in the labs, where we're going to compare different methods, what the bootstrapping methods give you is a way of creating these empirical sampling distributions, like we did in the IV paper. So what you can do potentially is you can estimate the bias, associated with using claims data alone, how that gets reduced by bringing in the linked clinical variables. What sort of effect does it have when you bring in kind of the, you do multiple imputation for all of the missing cells that you have? And the bootstrapping is nice in that context because you can take each one of those and you can estimate them, 500 to 1,000 times, get a distribution, and then compare the distributions. And that's just not, it's not a huge deal to do that anymore with the kind of computer power we have. The machine that we have, for example, we have a Teradata box for this, and it will, we've got this query tool that we call natural history disease that allows you to be able to, with drop-down menus, specify inclusion and exclusion criteria for procedures and drugs that people have been on and so forth. And then right now it does a very simple match, exact match of people that didn't get that treatment or that don't have that disease, but it matches them by gender and by age and by hospital referral region and so forth. And so you look at the data and it looks like a propensity score. So it's all balanced. But we are going to extend that to include propensity score matching. But when you do this bootstrapping, or when you do this natural history disease on this Teradata box, first it's already kind of gathered all the codes in these drop-down menus, so you don't have to go running around the ICD-9 manuals and procedure code manuals and stuff to extract the codes and then put them into SAS or Stata or R or whatever it is you're using. Then do the ETL, this massive database, and wait for it to come back, and then write programs to create the tables and so forth. That is like a 3-week process to do all that, and this natural history disease tool does it in about 12 seconds, hitting up against this huge database. So
Is that the SAP machine or what's the gadget? What's the tool you're talking about?
the natural history disease,
Yeah.
it's a homegrown tool. Yeah. So what we're doing is we're offering for the partners in the lab, it sits within these virtual sandboxes so that they can kind of do rapid assessment of feasibility of questions. It's not the research tool to actually answer the question, but it helps you to kind of weed out a lot of stuff very quickly.
Well, thank you. Oh, yes, go ahead.
In terms of the data like you showed on reducing missing variables problem, just wondering, have you been able to identify certain data sets that have been more helpful in solving that problem than others, and were there any surprises or
Yeah, well,
I just think like the marketing data.
yeah, that's true. So one of the things that's interesting about AARP is they've got all kinds of consumer data. And with this marketing company, who shall remain nameless for the time being, they have, we just got just a very limited number of variables, but they've got all kinds of stuff. So the challenge is if we bring in a lot of detail on what magazines people buy and, their expenditures on automobiles and cars and heat and all that sort of stuff. I think that's really important because I think people make decisions around health insurance and seeking health care and so forth in the context of a family budget. So bringing that data in, I think is very important. And I think even what we have in terms of just the income variables and race ethnicity is very important. So I think that's a big one. And I think if I had to say three, I would say consumer data, clinical data, clinical severity data from the electronic health records, and then the third is patient-reported outcomes. And the patient-reported outcomes, that doesn't sit in most of these data systems unless you're getting the data from a mental health clinic and they're collecting it PHQ-9 as part of their assessment of the patients and part of the clinical practice. But it's interesting because when you look at the healthcare utilization data, really high cost patients, 50% of them either had no cost or very low cost in the previous 6 months. So something like just a SF36 or an SF12 measure of health status gives you about a 15% lift in terms of variance reduction in predicting healthcare utilization because you're basically capturing some of the variance that you were missing before because if you didn't have the explanatory variables in the prior period using just the claims data alone. So I'd say those are the major domains. And there's a lot. So PCORI is obviously an area where there's a lot of focus on patient-centered outcomes and collecting data. But that data is going to have to be linked to this other administrative data that we have.